Welcome back to the Deep Dive. I'm looking at the surgical schedule this week, and we are seeing, an unnerving trend. Patients presenting with acute, non-traumatic, really severe knee pain, where the imaging doesn't immediately scream, ACL tear or displaced fracture. This is just a perfect setup for a high-stakes grand rounds review. Today, we're moving past the garden variety degenerative change and diving deep into osseous pathology, specifically this non-traumatic death of bone in the knee joint.
Yeah.
This is where those subtle signs, they really matter, because missing an early diagnosis completely changes a patient's entire trajectory.
It's a critical differential diagnosis, definitely. And you're right, the vocabulary alone can trip people up. We have to be meticulous about our terminology.
Right.
When we talk about osteonecrosis or on-in, we are technically describing the in situ death of a segment of bone. It happens because the osseous blood supply gets compromised. Fundamentally, it's a vascular catastrophe leading to cell death. And while we often think about it in the hip, the dreaded femoral head, AVN, when it happens in the knee, the morbidity can be rapid and honestly absolutely devastating to joint function.
And for the practicing surgeon or, the learner listening, we absolutely cannot treat this as just one single diagnosis.
Right.
It's like saying a hip fracture is just a hip fracture. The etiology dictates everything. We have to differentiate between three major, though histologically similar, conditions that affect the knee.
Exactly. You can almost think of them as three distinct cousins. They all show up at the same family reunion, which is the knee joint, but they got there through completely different ways and for very different reasons.
Yeah, I like that analogy. So cousin number one, the one that we often have to rule out first, is sort of the systemic actor. Secondary osteonecrosis. This is basically synonymous with classic avascular necrosis, or AVN.
Right.
And this entity, it's defined by having known identifiable systemic risk factors. We're talking things like high dose, chronic corticosteroid exposure, heavy alcohol use, chemotherapy, certain blood conditions like sickle cell disease. If you find one of those systemic drivers, it falls into this category.
Precisely. Then cousin number two is the real enigma, the one that makes us scratch our heads in the clinic. Spontaneous osteonecrosis of the knee, or SPONK.
C-O-N-K. Always a memorable acronym.
It is, and it's a classic distinct clinical entity. Its definition actually relies on the absence of those systemic predisposing factors we just mentioned. It was first really meticulously documented by Allback and his colleagues way back in 1968. A landmark paper, really, that separated this condition from other kinds of knee degeneration. You can see that foundation in our materials in text figure 3.
Got it. And finally, the iatrogenic relative, the one that, keeps us up at night. Osteonecrosis in the postoperative knee, or ONMPK. This is a recognized, thankfully rare, but profoundly significant complication that can follow routine, high-volume arthroscopic procedures, like meniscectomy, ACL reconstruction, maybe chondroplasty. Brahma and colleagues were the first to report this connection back in '91. It's referenced in text figure 14.2
Wow.
It really highlights the fact that sometimes our own intervention can inadvertently trigger the disease process.
Yeah, it's a tough one. So our mission today is really to pull apart these three cousins. We need to look at their clinical fingerprints, their radiographic signatures, their distinct etiologies, and maybe most importantly, their prognosis.
Right.
For you, the learner listening, identifying those critical prognostic factors is absolutely paramount because it's the difference between prescribing, crutches and an anti-inflammatory or planning for a total knee replacement down the line. We need to know when to pull the plug on conservative management and when we need to intervene aggressively.
Okay, let's start with SPONK then. It is perhaps the most common neon we encounter, and clinically, it often throws people off because of its sudden, really dramatic presentation. What's the classic patient profile walking into our office?
The profile is actually highly predictable. We're typically looking for an older patient, usually in their 5th or 6th decade of life. And critically, SPONK is highly biased toward women. We see it maybe 3 to 5 times more commonly than in men.
Wow, okay.
And the location. Almost pathognomonic. It's usually a focal lesion in the medial femoral condyle, specifically positioned just proximal to the joint line. Now, while we have seen rare cases in the lateral condyle or the tibial plateau, even the patella, if you see that focal medial lesion in an older woman with acute pain, you have to immediately suspect SPONK.
And the pain signature is really what sets it apart from just routine degenerative arthritis, right? It's not that gradual increase in ache. It's the sudden onset of severe pain, often localized right to that medial joint line.
Absolutely. The patient can usually pinpoint the onset, sometimes to a specific day or maybe a minor event they barely noticed. And during that acute phase, say for 6 to 8 weeks, they report excruciating pain with weight bearing. But the signature symptom, the one that really distinguishes this from a simple mechanical issue, is the significant increase in severity at night, often wakes them from sleep.
That nighttime pain is a huge red flag.
It really is. On examination, we typically see a small to moderate effusion, maybe limited range of motion because of guarding and spasm, and crucially, highly localized tenderness directly over that affected medial femoral condyle, especially when the knee is flexed to about 90 degrees.
Okay. Now let's dive into the deep end of the orthopedic pool here, the etiology. This is the classic chicken or the egg debate, isn't it? Is the bone dying because of a lack of blood, the vascular theory, or is it breaking because it's weak and then dying secondarily, the traumatic or insufficiency fracture theory? Let's unpack that insufficiency fracture side first.
Right, the traumatic insufficiency fracture theory, it holds strong, largely because of the patient demographic. Older postmenopausal women with a high prevalence of, well, osteoporotic or osteopenic bone.
So weaker bone to start with.
Exactly. The fundamental argument here is that the bone is structurally insufficient to handle routine everyday loads.
So just normal walking or maybe some minor non-reportable trauma causes these microfractures in that weak subchondral bone. It's a mechanical failure first.
Precisely.
Yeah.
The sequence proposed by researchers like Arnoldi and others, you can see it in text figure 9, is mechanical insult leading to microfracture. Once that subchondral plate is breached, joint fluid, which is under pressure, remember, it enters the intercondylar region.
Oh, okay.
This fluid entry then increases the interosseous pressure dramatically.
Yeah.
This internal pressure then basically acts like a tourniquet, leading to focal ischemia and secondary necrosis. The bone is essentially strangled by the fluid pressure after it is structurally failed.
And the most compelling counterpoint to the traditional AVN or osteonecrosis terminology comes from the histopathology, right? Which is fundamental to this debate. If primary necrosis were the rule, you'd expect every specimen to be just overwhelmingly necrotic.
That's right. And this is where the work by Mears et al. Was so revolutionary in shifting our understanding. They looked at histopathology from 24 SBONK specimens, that's in text figure 43.3 LERTs, and their findings were striking. They found definitive evidence of bone necrosis in only one of those 24 patients.
Only one. Wow.
Only one. However, a staggering 75% of those same specimens demonstrated frank osteoporosis.
Okay, that data fundamentally challenges the name osteonecrosis, doesn't it? I mean, it's 75% of your sample show structural weakness, the osteoporosis, but only 4% show actual bone death. We really have to start recognizing the insufficiency fracture as the primary initiating event. And the necrosis, when it occurs, is more of a secondary phenomenon following the fracture and maybe a failed remodeling attempt. Are we essentially misnaming SBONK? Should we be calling it subchondral insufficiency fracture or SEIF of the knee?
Clinically, yes, that's certainly where a lot of the evidence is leaning. But, it complicates the picture slightly because some element of vascular pathology might still be at play, at least in some cases.
Okay.
Let's look at the pure vascular theory for a moment. In femoral head AVN, we see really high rates of thrombophilia or coagulopathy. Maybe up to 75% of patients show something.
Right, that link is strong in the hip. How does that compare to the SBONK knee?
It's far less consistently demonstrated in the knee. We just don't see that strong systemic thrombotic connection as often. However, we can't entirely dismiss the vascular angle. And this leads us to that fascinating and I'd say highly provocative small series published by Grook and colleagues.
Ah, yes. This study is intriguing because it actually offers a potential pharmacologic intervention, which is rare here. They evaluated just 6 patients, right? Early, stage 2, SPONK, who also happened to test positive for some underlying thrombophilia or hypofibrinolysis.
Exactly, 6 patients. And their treatment was pretty straightforward. Aggressive anticoagulation using either enoxaparin or rivaroxaban. The goal was essentially to prevent microthrombi from forming, or maybe resolve them if they were present, thereby restoring perfusion and hopefully preventing progression.
And the results for such a small study were quite dramatic, weren't they?
They were. Before treatment, all 6 patients needed some form of assistive device like crutches or a cane because of the pain. Post-treatment, none required them. And perhaps more importantly, none of them progressed to joint collapse or severe degenerative change over a 15-year follow-up.
15 years is impressive follow-up, but it raises a critical question for you, the practitioner listening. Are we really going to put elderly, potentially fall-risk patients on powerful anticoagulants based on an NEL6 data set?
Yeah, the answer has to be guarded. Right. Probably not routinely. But it absolutely warrants further investigation. It implies that for maybe a small, identifiable subgroup of sequelae OK patients, there might be a primary vascular insult that, if treated early, could halt progression. It certainly argues for at least considering a basic thrombophilia workup in those early Spec 1K patients, especially if they don't have an obvious meniscal tear driving things.
That's a great clinical pearl. Consider testing for coagulopathy if the picture's a bit ambiguous. But let's look at the third, and you could argue maybe the most mechanistically dominant theory these days, the meniscus connection. In the orthopedic community, we know there's just a staggering association between medial meniscal tears, especially root tears, and SPONK.
Oh, the association is overwhelming, and it really bridges the gap between the mechanical and the vascular theories in a way. Robertson et al. In text figure 65 reported meniscal root tears coexisting with SPONK in 80% of their cohort.
80%.
Yeah. Other series consistently show coexisting tears in the 50% to 78% range. This is not a coincidence. It's pointing towards a foundational biomechanical flaw.
Let's break down the mechanics of hoop stress, because this is where the physics of the knee becomes really unforgiving. The intact circumferential meniscal fibers, they distribute load outward, creating what we call hoop stress, right? And that prevents direct central compression on the subchondral bone.
Precisely. You can think of the meniscus like a pressurized tire on a wheel. If you have a tear, particularly a root tear, where the meniscus essentially gets pulled out of its anchor to the bone, you instantly lose that circumferential tension, and therefore you lose the hoop stress distribution.
So when that foundation is compromised, the load is no longer distributed nicely. It gets concentrated and focused directly onto that medial femoral condyle. What's the magnitude of that load increase we're talking about?
It's massive. Ahmed et al. Looked at this text figure for tile dollars. They reported that even a partial meniscectomy can increase tibiofemoral contact pressures by up to 85% when the knee is in 90 degrees of flexion.
85% increase.
Imagine an already osteoporotic, maybe slightly weakened bone suddenly having to withstand nearly double the focal pressure it's used to. This altered excessive loading creates the ideal environment for a subchondral insufficiency fracture to occur. So the meniscal tear is kind of the structural primer for the insufficiency fracture, which then leads to that sequence of edema and potential secondary necrosis.
It's like a cascading failure. Weak bone plus lost hoop stress plus a massive pressure spike equals structural collapse.
That sums it up perfectly. And that brings us right to the critical aspect of management. How do we stage this disease accurately to predict failure?
We start with plain films, obviously, but as we said, they're often misleadingly normal in the early stages, despite the severe pain. Once changes are evident, we rely on established staging systems. Cuscino's four-tiered staging is the classic, but Aglietti offered some useful modifications too.
Right. Cuscino stage 1 is the incipient stage. The patient has the pain, but the X-ray looks negative. Stage 2 is termed avascular, where we begin to see that characteristic subchondral lucency, maybe surrounded by some reactive density or sclerosis. Stage 3 is the painful milestone definitive subchondral collapse, often with a clear sclerotic halo around it. This is what we're desperately trying to avoid. And then stage 4 is the endgame, collapse plus secondary degenerative changes throughout the joint.
Aglietti modified this into a 5-tiered system, and I think it offers a really crucial clinical addition. He kept stage 1 as X-ray negative, but he introduced stage 2 as subtle flattening of the condyle contour. Why is finding that subtle flattening, maybe on a stress view, so important?
Because that subtle flattening indicates that microfracture and collapse are likely already underway, even if the classic lucency isn't fully formed yet. Finding that stage 2 subtle flattening should really change our immediate treatment pathway. We move from maybe watchful waiting to immediate, strict, protected weight bearing, or potentially even considering core decompression because we know collapse is probably imminent.
Makes sense.
Aglietti's stages 3 and 4 then track the increasing size of that lucent lesion and the sclerotic halo before you get to full joint destruction in stage V.
But regardless of which staging system you prefer, the prognosis seems overwhelmingly tied to one specific number: the lesion size ratio. This is the objective, magnification-independent gold standard for prediction, isn't it?
Precisely. You calculate this ratio simply by comparing the lesion width to the overall width of the condyle on the AP X-ray view. This is the data point that should really drive your decision-making and your conversation with the patient. We know that good outcomes, meaning self-healing, no need for surgery, are overwhelmingly associated with lesions where this ratio is less than, say, 0.45.
Okay, less than 0.45 is good. Conversely, what's the critical line in the sand that separates potentially salvaging the joint from almost certain progression to severe arthritis?
The line seems to be around 0.5. If the lesion width is 50% or more of the overall condyle width, that patient is walking a tightrope, and failure, meaning progression to collapse, is highly likely. The data supporting this is pretty stark. Studies have shown 0% of patients with lesions less than 0.2 required surgery, compared to a devastating 85.7% of patients with lesions greater than 0.4 needing some form of surgical intervention during follow-up.
Wow, that's a huge difference.
It is. So when we're counseling patients about non-operative management, that ratio is the key prognostic measure we have to discuss.
And since plain films are often late to the party, NRI becomes our diagnostic workhorse. It's highly sensitive. What's the magnetic signature we're looking for that really confirms on-N?
The hallmark sign, the classic finding, is the serpiginous low signal line that defines the margin of the necrotic bone. On T1 weighted images, you see the central low signal area, that's the dead bone, maybe some fibrosis. The serpiginous line delineates this area from the adjacent living bone that's reacting to it. Then on T2 weighted images, you typically see high signal intensity right at the edge of that line. This represents the bone marrow edema, basically the body's inflammatory response to the necrotic tissue.
And if we use gadolinium contrast, what are we looking for there? Does that help determine healing potential?
It can. Gadolinium enhancement right at the perimeter of the lesion is generally considered a good prognostic sign. It tells us there's vascular activity, there's blood flow, there's osseous turnover happening at the lesion margins. The body is actively trying to wall off and heal the damaged area. Conversely, a lack of enhancement suggests a more biologically inactive lesion, which might have a higher propensity for continued collapse.
Got it. So clinically, the acute intense pain period lasts about 6 weeks, you mentioned. That 6-week mark seems like a real inflection point where we can start to separate the satisfactory prognosis group from the poor prognosis group.
Correct. The satisfactory outcome group typically sees their pain starting to improve after about 6 weeks. Now, they might still be symptomatic for, 12 to 18 months, but the overall trend is improvement. And these are almost always our small lesion patients, the ones with less than 40% condyle width involvement.
Okay.
The poor prognosis group, unfortunately, fails to improve after 6 weeks. Their symptoms are relentless. They usually have the larger lesions, greater than 50% width, and they often progress rapidly to collapse and degenerative changes. While Insall's work, referenced in text figure 29.9, showed that virtually all SPONK patients eventually develop at least grade IOA within about 2 years, the poor prognosis group sees significant functional failure much, much faster.
Okay, let's move on to ONPK. Yeah, the complication that puts a pit in your stomach. This is the patient who had a perfectly routine scope, maybe for a medial meniscal tear, but then 3 months later they come back and their pain is actually worse than before the surgery, and then you get an MRI and you start seeing those familiar dreaded signal changes.
Yeah, it's rare, thankfully, but clinically devastating when it happens. And given the sheer volume of arthroscopy performed, even a minuscule complication rate generates a significant number of cases over time. It's reported following meniscectomy, ACL reconstruction, even chondroplasty. As you said, Brahm et al. First described this clearly back in 1991. That's text figure $14.
The patient profile here offers some key differentiators from ICI-O-N-K, doesn't it? While they're still generally older, maybe mean age around 58, the gender distribution is roughly equal. We don't see that strong 3-to-1 or 5-to-1 female predominance like in ICI-O-N-K.
That's right. It's about equal gender distribution. And critically, the location is predictable. ONPK is almost always geographically tied to the surgical compartment. We rarely see it develop somewhere else in the knee. Of the reported cases, something like 39 out of 47 affected the medial femoral condyle.
Which just reflects where most scopes happen.
Exactly. It reflects the fact that medial meniscectomy is by far the most common procedure performed. The lesion develops directly beneath the area where we were operating.
Clinically, the picture is persistent or worsening pain, maybe swelling limited range of motion after the surgery. But the diagnosis itself sounds like a bit of a tightrope walk, because we have to definitively rule out the possibility that the patient already had a brewing, maybe stage I SPONK lesion before they even entered the operating room.
This is where rigorous diagnostic criteria are absolutely essential. Criterion number 1, absence of unwan preoperatively. If the patient had significant symptoms before the surgery, we must demand a preoperative MRI, and critically, it needs to be performed about 4 to 6 weeks after those initial symptoms began.
Why that specific window, 4 to 6 weeks after symptom onset?
Because we know from various studies, including animal models like Nakamura et al.'s work, shown in text figure 504.4, that it takes time for those characteristic signal changes of ON to actually develop on an MRI following a potential vascular insult or microfracture. If we scope the patient too soon after their acute onset of pain, we risk operating on an existing but MRI negative, stage I SPONK. Then, when it progresses naturally, we might wrongly label it as an iatrogenic ONPK. That 4 to 6 week waiting period is essential to try and confirm that the pre-op subchondral bone was stable and normal before our intervention.
That makes perfect sense. Okay, so criterion 1 is a clean pre-op MRI after that waiting period. What's criterion 2?
Criterion 2 is the temporal association. We need a clear link in time between the arthroscopy itself and the definitive appearance of osteonecrosis on a subsequent MRI. In the case series reported by Pape et al., referenced in text figure 588A, the mean time from the arthroscopy to the ONPK diagnosis was about 18 weeks, but the range is heated anywhere from 3 weeks up to over 3 years, believe it or not. So we need to remain vigilant for quite a while following surgery.
We also need to exercise some clinical caution here, right? Because just seeing some bone marrow edema on a post-op MRI isn't automatically ONPK. That edema can be transiently common after arthroscopy, especially in younger active patients.
That's a vital caveat, yes. Studies show maybe up to a third of younger patients might show some bone marrow edema after a meniscectomy, but it typically resolves without any long-term issues. The problem arises when that edema persists, or say by 3 months postoperatively, it starts to coalesce into that familiar low-signal, maybe serpiginous pattern on the T1 images. That's what signals trouble and raises concern for true ONPK.
Okay, let's look at the proposed etiology specific to this post-op environment. The insufficiency fracture theory seems still dominant, but now the idea is that we, the surgeons, are the ones who inadvertently modified the mechanics to induce it.
Right. The primary theory here is biomechanical alteration due to the procedure itself. When we perform a partial meniscectomy, even a small one, we significantly alter the load transmission across that compartment. We already mentioned Ahmed et al.'s findings, text figure $44. Removing even a small piece of meniscus can dramatically increase those tibiofemoral contact pressures.
It's the law of unintended consequences, really. We remove the painful pathology, the torn meniscus, but in doing so, we potentially destabilize the foundation and increase the focal stress on the bone.
Exactly. This massive increase in contact pressure on the remaining subchondral bone, which might not be osteoporotic yet, but is certainly being subjected to peak forces it wasn't designed for, can lead directly to insufficiency fractures.
And this ties back to our own protocols, potentially. Think about overly aggressive rehabilitation. We often tell the patient to immediately resume weight-bearing, get moving quickly. But if the bone hasn't had time to react and remodel to that massive load alteration following the meniscectomy, could that rapid resumption of weight-bearing actually precipitate the insufficiency fracture? Are we potentially creating ONPK through our, zealous desire for a rapid functional return?
It's a very plausible theory, and one we need to consider seriously. The second major theory involves direct iatrogenic injury during the scope itself, specifically fluid and thermal damage. This is a risk specific to the operating room environment.
How would fluid cause this?
Well, the hypothesis is that increased articular cartilage permeability, maybe due to the instruments we use or the initial pathology itself, allows the arthroscopic fluid we pump in to penetrate into the subchondral bone area. This influx creates subchondral edema, which can rapidly increase the intraosseous pressure within that confined space. It's like turning on a faucet in a closed compartment. The increased pressure essentially chokes off the local vascular supply, potentially leading to necrosis.
Okay, like a compartment syndrome in the bone. And the direct thermal, or maybe chemical insult theory, implicates the tools we actually use. Guarino et al., text figure 2077, discussed thermal injury from things like radiofrequency probes or lasers used during chondroplasty.
Exactly. When we use an RF probe, for example, to smooth out cartilage edges, we generate heat. Bone is actually highly sensitive to temperature spikes. Localized hyperthermia can directly cause focal apoptosis-programmed cell death and subsequent necrosis of the osteocytes. It's essentially creating the necrotic margin right at the site of our surgical intervention. A direct physical insult leading to bone death, which is distinct from the biomechanical failure mechanism we discussed after meniscectomy.
Now, regarding prognosis, ONPK sounds profoundly unforgiving compared to SOPONA.
It is. Unlike those small SBONK lesions, which often heal with protection, non-operative treatment for ONPK is largely unsuccessful. One series reported only about a 6.4% success rate with protected weight bearing. The progression rate is terrifyingly high. Something like 93.6% of reported cases either had permanent lesions or progressed to irreversible stages requiring subsequent surgical intervention, usually arthroplasty.
And here's a critical differentiation for the learner. In SBONK, we hammered home that lesion size dictates prognosis, but in ONPK, that correlation is far less reliable, correct?
That's absolutely correct. In ONPK, even small areas of postoperative bone marrow signal changes that we might watch benignly for a while in a SBONK patient, seem to have the potential for rapid progression to collapse. The underlying mechanism might be slightly different, or the post-surgical environment is just less forgiving, but the aggressive clinical course demands urgent attention and possibly intervention, often regardless of the initial lesion size on MRI. We have to be much more concerned about any persistent post-op signal change that looks like ONPA. Okay, so we've established the two knee-specific types, SBONK and ONBK. Now let's quickly synthesize the three, because rapid and accurate differentiation is really the primary skill needed for selecting the proper management pathway. We need to internalize these key comparison points, like those laid out in Table 35.1 and Box 35.1 in our materials.
Right. Let's start with the demographics again. Secondary AVN, that's the disease of the relatively young or middle-aged joint, typically.
Absolutely. Secondary AVN usually affects a much younger patient population, often text 45 years old or younger, people who are generally active. SBONK and ONTK, conversely, are diseases of the older, often osteoporotic joint, generally text 55 to 60 years or older old. So, if a 35-year-old presents with knee on, your first thought should immediately be secondary AVN, and you start searching for those systemic causes.
And the most potent differentiating factor is the systemic involvement, which you called the rule of 80-90. Let's break that down again for the listener.
Right. The rule of 80-90 refers to the highly characteristic multifocal and bilateral nature of secondary AVN. If a patient has secondary AVN in the knee, it's bilateral, meaning in both knees in over 80% of affected patients.
Okay, 80% bilateral.
It also commonly involves multiple condyles within the same knee, maybe medial and lateral, which is different from the typically focal, single condyle nature of STECH-AN or ONPK.
And the 90 rule.
The 90 rule is that over 90% of secondary AVN cases in the knee also involve other anatomical sites, most notably the femoral head. So if your patient has knee on N, you absolutely must get a hip x-ray, probably an AP pelvis. If the hip is involved, you're definitively dealing with secondary AVN, and your whole treatment plan and prognosis changes dramatically. It also frequently involves the proximal humerus, the shoulder.
Right, whereas SBONK and ONPK are almost always isolated and unilateral.
Exactly. Bilateral involvement in SPONang or ONPK is rare, less than 5% of patients. So that systemic multifocal pattern is a huge clue for secondary AVN.
That immediately guides the diagnostic workup then.
Yeah.
If I see neon, especially in a younger patient, I'm ordering labs to screen for systemic risk factors and definitely getting x-rays of the contralateral knee and both hips, maybe even shoulders.
Precisely. And those identifiable risk factors are Keybox 35.1 lists the main culprits. Chronic high-dose corticosteroids are a big one. Chemotherapy, significant alcohol abuse, sickle cell disease, systemic lupus, history of organ transplant. Secondary AVN is essentially defined by the presence of one or more of these systemic factors. SPONK and ONPK are defined by their absence.
Makes sense. And finally, the clinical onset provides another massive clue. SPONK is typically acute and severe. Secondary AVN is often more gradual and insidious, right?
Generally, yes. Secondary AVN patients often report a more gradual increase in pain, which might be mild and even bilateral initially, reflecting that multifocal nature of the disease process. This contrasts pretty sharply with the acute, sudden onset, severe, localized pain that characterizes SBONK. Usually you can sort them into the right diagnostic bucket just with a good history and a quick set of screening x-rays.
Okay, so diagnosis and staging are half the battle. Now we need to transition to management. As we mentioned, there isn't really a single validated algorithm, so we have to individualize care based on the patient's age, their activity level, and most importantly, the specific type and stage of on-on they have.
The overriding principle is fairly simple, though. For early disease, meaning pre-collapse stages HER or 2, we attempt to preserve the joint. The goal is to reduce load and promote healing. For late, already collapsed disease, stages 3 or 4, we're generally moving towards joint replacement. ###A, non-operative and pharmacologic treatment.
Not operative management, which usually begins with protected weight-bearing crutches. Maybe partial weight-bearing is the first step, typically for maybe 4 to 8 weeks. But its success rate depends entirely on which cousin we're dealing with.
Absolutely. If we're dealing with secondary AVN, non-operative management is unfortunately largely doomed to fail. Because of the typically large lesion size and the underlying systemic issue that's often still active, Mon et al., in text figure 4 at 6 reported only about a 20% successful outcome at 8 years follow-up for knees with secondary AVN treated non-operatively. So in secondary AVN, we usually need to proceed fairly rapidly to some form of intervention.
But for those small SPO-NK lesions, non-operative management can actually shine, can't it?
Yes, absolutely. If the lesion size ratio is small, say less than 0.4, or if it's clearly stage I or maybe early stage 2 on imaging, protected weight bearing is highly successful. Lotke et al., that's text figure 45, showed symptom resolution in nearly 90% of their stage ISBL-NK patients treated with protected weight bearing alone. Yates et al., text figure 69 non, confirmed resolution on follow-up MRI in 19 out of 20 stage I cases they followed. So for small, early CPNK, conservative care often wins.
And what about O and PK? Where does non-op fit there?
Less successful than for SEPUNK, certainly. That one series suggested only about a 6.4% success rate for ONPK, improving with non-operative treatment alone. Given the highly reliable progression we see in ONPK, we probably need to be much quicker to move past protected weight bearing than we would be for a benign-looking, small SPONK lesion.
Okay. To help protect the joint from those compressive forces, especially if the patient has a varus knee alignment, we sometimes use unloader braces. Let's talk briefly about the mechanics of how these braces actually help offload that vulnerable medial femoral condyle.
Right. The mechanism is basically biomechanical redirection. The unloader brace applies a valgus force, a force pushing outwards during the gait cycle. This reduces the adduction moment across the knee. The adduction moment is the natural force that tends to push the knee into varus, or bow-leggedness, during weight bearing. By reducing this moment, the brace effectively shifts the weight-bearing axis laterally towards the outside of the knee, taking pressure off the compromised medial femoral condyle. Lindenfeld and colleagues, in text figure 381, showed that these valgus-producing braces could achieve pain reduction of almost 50% and functional improvement of nearly 80% in symptomatic patients with medial compartment issues. So it can be a powerful tool for symptomatic relief and potentially joint protection.
Makes sense. Now let's look at the pharmacologic side. We know bisphosphonates, like alendronate, are highly effective in treating femoral head AVN. They work by promoting bone formation and reducing osteoclast activity. Did we manage to translate that success to the knee?
Unfortunately, no. The results in the knee have been pretty disappointing. Despite the clear success in the hip, a researcher named Meyer conducted a proper randomized controlled trial specifically for SPONK. They compared ibandronate, a bisphosphonate, against placebo and just standard anti-inflammatories.
And the result?
They found no benefit of the ibandronate over placebo, both in terms of pain relief and radiological progression. So currently, we generally save the bisphosphonates for the hip AVN patient, not for SPONK in the knee.
Okay, that provides important clarity. So for SEPUNK non-operatively, we're sticking mainly to weight protection and maybe NSAIDs.
Yep.
However, we circle back to that potential vascular subgroup. If we do confirm thrombophilia, we should consider anticoagulation.
Yes. Based on Glueck's small but I think compelling N6 series, if we identify an underlying coagulopathy, which suggests a potential vascular etiology, then anticoagulants like enoxaparin or rivaroxaban are potentially indicated to try and modify the disease course.
Okay.
Similarly, for patients who present with massive bone marrow edema syndrome, which sometimes overlaps clinically with early on, vasodilators like iloprost are sometimes employed, though the data specifically for large SPONK lesions treated this way is still evolving. #B joint-preserving surgical interventions.
All right, so when non-operative management fails in those early-stage pre-collapse lesions, stages 1 or 2, we move to joint-preserving surgical procedures. Core decompression, or CD, seems to be the cornerstone here. The goal sounds simple enough: relieve that elevated intraosseous pressure.
Exactly. CD involves drilling into the affected area of bone, usually from outside the joint, to create channels. The idea is to allow that high-pressure fluid to decompress and hopefully also stimulate some revascularization or healing response. We generally prefer antegrade drilling, meaning drilling from above the lesion, extra-articularly over retrograde drilling, which comes up from inside the joint.
And why the preference for antegrade?
mainly because the antegrade technique avoids violating the intact articular cartilage surface. If we're trying to preserve the joint, the last thing we want to do is create more damage to the cartilage itself. Antegrade drilling also sometimes allows for better localization of the lesion.
Makes sense. What kind of results can we expect from core decompression, and for which conditions is it best utilized?
CD has shown pretty encouraging results, particularly in early-stage CES-PONG. Forced et al. And text figure 25 Tama reported symptom relief and successful healing in 15 out of 16 early-stage SPONK patients they treated with CD. It's also really our go-to surgical option for early pre-collapse secondary AVN, especially in younger patients. Monta et al., text figure 49.9 reported good to excellent results in 72% of secondary AVN knees treated with CD at an impressive 11-year follow-up.
11 years is significant.
It is, since secondary AVN often affects younger patients, delaying the need for a knee replacement by a decade or more is a massive win for them.
Okay. Our second main joint-preserving surgical option is high tibial osteotomy, or HTO. This sounds like it's reserved more for our younger active CES-PONK or maybe ONPK patients who have clear medial compartment disease and also an associated varus or bow-legged alignment.
That's exactly right. HTO is purely a mechanical realignment procedure. It's orthopedic geometry, essentially. The goal is to surgically cut and realign the upper tibia to aggressively shift the weight-bearing mechanical axis of the leg laterally towards the outside. This creates a valgus, or slightly knock-kneed alignment, which effectively offloads the damaged medial femoral condyle. We're literally changing the physics of the gait cycle to protect that vulnerable bone.
And Koshino's long-term work, referenced in text figure 367 time, really established the goalposts for how much correction we need. It sounds like if we're going to do an HTO for on, we can't be timid about the correction.
Exactly. Koshino demonstrated quite clearly that the best outcomes, meaning the lesion actually improved or resolved radiographically, were achieved only when the mechanical axis was corrected to at least 10 degrees of valgus alignment. Undercorrecting means the pressure on the medial condyle remains too high and failure is likely. Of course, overcorrecting too much risks creating joint line obliquity and increasing lateral compartment pressure, so it's a delicate balance, but achieving at least that 10 degrees of valgus seems critical.
And crucially, HTO is generally contraindicated for secondary AVN. Why can't we use this powerful realignment technique for a patient with, say, steroid-induced AVN?
Because secondary AVN is, by definition, usually multifocal and often bicondylar. It might involve the lateral femoral condyle just as much as the medial, or it might involve the tibial plateau as well. An HTO might successfully offload the medial femoral condyle, but it does absolutely nothing for a concomitant lesion in the lateral femoral condyle or the tibial plateau, which are common in secondary disease. You simply can't offload all the potential necrotic foci simultaneously with an HTO. ##C knee arthroplasty, the final treatment. So if joint preservation fails, or if the patient presents initially with advanced collapse, like stage 3 or B, and maybe widespread degenerative changes, then we have to move to arthroplasty or joint replacement.
For a disease that's strictly isolated to a single compartment, which is often the case for typical medial femoral condyle SPONK lesions, unicompartmental knee arthroplasty, or UKA, seems like the preferred option, right? It's generally less invasive, preserves more bone stock, and importantly, keeps the crucial ACL and PCL ligaments intact.
Yes, and the outcomes for UK performed for isolated on-in are generally excellent. Bruni and colleagues reported a survivorship of 89% at 10 years. For UKAs performed specifically for isolated medial compartment SPONK. It appears to be a durable procedure when the disease is truly confined to one area.
Okay, then total knee arthroplasty, or TKA, is reserved for the most extensive cases, like secondary AVN with its multifocal involvement, or maybe advanced SPONA or OMPK that has progressed to involve the contralateral compartment or the patellofemoral joint.
Exactly. TKA is the definitive solution when multiple compartments are involved or severely degenerated. Now, here is a massive clinical caveat for the learner listening. Exactly the same as a TKA done for standard primary osteoarthritis. The literature actually suggests that TKA outcomes for particularly SPONK may be somewhat inferior.
Inferior? How so? Ritter et al.'s work in text figure 64-2 really highlighted this disparity, didn't it?
It did. They compared TKA outcomes in patients with SBONK versus a matched cohort with primary OA. They found that the SBONK patients reported worse pain relief, only 82% good excellent pain relief compared to 90% in the OA group. And perhaps more concerning, they had a significantly higher incidence of needing revision surgery down the line, 17% in this SBONK group versus 0% in their matched OA cohort at that follow-up point.
17% revision versus 0. It's a huge difference. Why? Why would the outcome be worse? Well, it's likely a combination of biology and perhaps persistent pain pathways. One theory is that small foci of osteonecrosis might still exist in the metaphyseal bones surrounding the implant surface, just outside the immediate area that we resected during the TKA. This persistent biological insult or pain stimulus could complicate the outcome. Secondly, necrotic bone is, by definition, biologically compromised. This might potentially affect long-term implant fixation and stability, perhaps contributing to that higher revision rate. While other researchers like Mont et al. Have certainly shown good knee society scores after TKA for ON, the general warning still stands. The underlying biology of osteonecrosis seems to make TKA a potentially more challenging procedure with slightly less predictable long-term outcomes compared to routine primary OA. So the take-home is we really have to manage patient expectations aggressively when we're performing arthroplasty primarily for an on-end diagnosis.
Absolutely. The baseline expectation for pain relief and longevity might need to be adjusted slightly lower compared to an OA patient, and we certainly must be vigilant for any persistent or recurrent pain post-operatively. #VSA. Conclusion and takeaways. So if there's one overarching clinical message from this entire deep dive, I think it's that maintaining a high index of suspicion is absolutely non-negotiable. Early, accurate diagnosis allows us the best chance to treat, for example, small SBONK lesions successfully with non-operative measures. But any delay in diagnosis almost guarantees progression, particularly in ONPK and secondary AVN, where the disease process seems much more aggressive from the outset.
Okay, let's run through a final checklist for our orthopedic colleagues listening. SPONK. Think older, usually female, acute onset of severe localized medial knee pain, absence of systemic risk factors, often linked biomechanically to meniscal root tears and underlying insufficiency fractures. Prognosis is tied tightly to lesion size. Protect the small lesions, prepare to replace the large ones.
ONPK. Remember, this is the postoperative complication. Mean age around 58, equal gender distribution. Diagnosis defined by that critical preoperative normal MRI after the 4 to 6 week window, and the clear temporal association to the arthroscopic procedure. Highly progressive, often regardless of initial lesion size. Non-operative management fails in about 94% of cases.
Right, and secondary AVN. Think younger patients, defined by the presence of systemic risk factors, steroids, alcohol, sickle cell, etc. Typically presents more gradually and characterized by that rule of 80-90 high rates of bilateral involvement and multifocal disease with frequent coexistence of hip AVN. For this patient, non-operative management is generally ineffective, so core decompression or arthroplasty must be considered much more quickly.
Looking forward, I think we have to focus our research not just on treatment, but also on prevention, if possible. We need to continue to solidify that biomechanical link in SBONK and ONPK and determine if simple, maybe prophylactic measures could modify the disease course. Should we be routinely screening for thrombophilia in all early SBONK patients, as Glick's small study suggested? Should we be adjusting our surgical techniques, perhaps being more mindful of thermal energy sources to minimize iatrogenic injury?
Which brings us right back around to our final provocative thought for the learner, and maybe a true challenge to our standard post-operative protocols. If the weight of the evidence increasingly points toward subchondral insufficiency fracture, often triggered by altered loading after meniscectomy, as the primary event in both SPMK and maybe OMPK, then our current strong push for rapid return to activity after a meniscectomy, especially for something like a medial root tear in an elderly patient, might actually be doing more harm than good in some cases.
We are creating a biomechanically altered joint, often in the setting of already weakened bone, and then we're asking that vulnerable bone to immediately bear full load. The difficult question is, should every elderly patient undergoing a medial meniscectomy, particularly for a significant tear like a root tear, automatically be treated more like a high-risk ONPK patient?
Meaning, should they get a mandatory strict period of protected, maybe even non-weight-bearing restriction, significantly slowing down our usual rapid post-operative rehab goals? How do we, as surgeons, justify that potentially lengthy protection period to a patient who, understandably, demands a fast recovery, when the alternative, even if rare, is potentially catastrophic joint collapse down the line? It's a really difficult conversation about risk and reality that I think we have to face as we continue to refine our postoperative protocols.
It suggests we're operating in a pretty precarious biological and mechanical environment sometimes, and the data might be hinting that in certain situations the best intervention is simply to slow the patient down.
A necessary and exceptionally detailed deep dive into a truly tricky set of diagnoses. Thank you for walking us through all these crucial distinctions today.
My pleasure. Always good to review these complex topics.